Now we are looking at side view of the eyeball, which is the right eyeball, and we want to look at some of the details of the muscles and the nerves. Examiners are giving you some diagrams identifying some muscles and nerves along with that. So just we need some orientation. You see, this is the common tendinous ring of Zinn, which is giving origin to the four recti muscle, which are inserting into the sclera. You see, this is the lateral rectus, and there's a superior rectus, inferior rectus. Medially, you can see medial rectus. I told you wherever they are inserting, just behind the insertion, the thinnest sclera will be there, that we know. Behind the attachment of any rectus muscle, maybe, this area is the thinnest sclera. That area will be the thinnest sclera. This area will be the thinnest sclera. This is one thing. Second thing is that a question is coming about the inferior oblique muscle. Inferior oblique muscle is passing under inferior rectus but deep to the lateral rectus before it insert on the sclera. Remember, inferior oblique muscle is passing under the inferior rectus muscle. Here you can see it is passing under inferior rectus and then passing deep to the lateral rectus so that it will insert into the sclera of the eyeball. Now we are looking at the nerves as well. You will see, we have known earlier, at the base of the brain, we could see some nerves, which is, most medially at the pontomedullary junction was the sixth nerve, whereas the number 3-4 come from the midbrain. So, now number 3-4 come from the midbrain, and abducens nerve is coming at the pontomedullary junction near the midline. This is the basic idea. Now you have to understand. Trochlear nerve, the number 4, is the formula SO4, so it is going to supply the superior oblique muscle. You can see here, this is a trochlear nerve, and it is going to supply the superior oblique muscle here. Then what is the lateral rectus doing? It is having abducens nerve. And where is abducens nerve? This is abducens nerve, and you see abducens nerve has come and supplying the lateral rectus. And then the green oculomotor. You can see the green is oculomotor, and oculomotor is giving superior division, inferior division. If you remember, we have discussed superior division is going to supply the superior rectus, and inferior division is going to supply the inferior rectus. So this is inferior rectus here, and that is superior rectus. You will also see that the superior division and inferior division, there are some other details which we have to discuss. But the thing was, when the nerves are passing through the tendinous ring of Zinn, trochlear nerve was left outside the ring of Zinn, and the number 3-6 are inside the ring of Zinn. And number 3 is already divided into superior inferior division. So it was actually superior and inferior division of the oculomotor nerve along with the abducens nerve, the 6th nerve, inside the ring of Zinn, whereas the trochlear nerve will be left outside the ring of Zinn. These are some of the details we have to remember. Plus, can you see the ciliary ganglion here? And when you are talking about the ciliary ganglion here, this is the ciliary ganglion. It is giving some short ciliary nerves towards the sclera of the eyeball. It will also give long ciliary nerve towards the sclera of the eyeball. So short ciliary and long ciliary nerves coming from the ciliary ganglion. What about those short ciliary, long ciliary? We'll have to talk about their supply in a short while. Now, as you are moving further, you can see it is the inferior division of the oculomotor nerve. It is the inferior division of the oculomotor nerve which is connected to the ciliary ganglion, which is topographically related with trigeminal. So that trigeminal will carry the post-ganglionic fiber. So which nerve carry pre-ganglionic? It is oculomotor nerve which is carrying the preganglionic fiber towards the ciliary ganglion, which is topographically related with trigeminal to carry the postganglionic fiber, which are short ciliary nerves. Where to? Where to? You remember oculomotor nerve supplying the two smooth muscles in the eyeball, namely sphincter pupillae and ciliaris. So sphincter pupillae and ciliaris are supplied by this pathway. Then what is the long ciliary nerve supplying? Long ciliary are actually sympathetic fiber to the dilator pupillae and superior tarsal muscle. Long ciliary will be the sympathetic fiber towards the dilator pupillae and superior tarsal muscle, which was compromised in Horner syndrome. This is parasympathetic pathway. So third nerve carrying some parasympathetic fibers, yes, to the ciliaris and sphincter pupillae muscle. Yes, that's the point. Okay. Now remember, abducent nerve is having longest intradural course. Why? Because I told you it will puncture the dura mater quite early. Where? At the floor of the posterior cranial fossa and run in Dorelio's canal to enter cavernous sinus. So it is quite long in the intradural space. So longest intradural is abducent. Then who is the longest intracranial? That is trochlear nerve. Trochlear nerve. Why it is longest intracranial? Because trochlear nerve is a cranial nerve which has a dorsal exit and then comes ventral. It becomes quite long in that course. Trochlear nerve is the only cranial nerve which will exit dorsal and make a turn and come ventral to supply the superior oblique muscle SO4, superior oblique. So it will become long. It has the longest intracranial course. Abducent has longest intradural course. Okay, so what about the lesions? If you are talking about number 3, which is coming from midbrain anteriorly ventrally, damage down and out eye. Why there's down and out eye? Let us find out. If you are talking about the trochlear nerve which came from the posterior side, if it is damaged, then the patient will develop a head tilt opposite to the side of lesion. Why there will be a head tilt opposite to the side of lesion? Say for example, the left superior oblique is not working. The head will tilt to right side. Contralateral head tilt. But why? Explain why. That will do. Trochlear nerve injury, superior oblique palsy. And what if it is sixth nerve injured coming at the pontomedullary junction, most medially? Then the patient will develop medial squint. Why medial squint? Because if lateral LR6 is not working, if LR6 is not working, the medial rectus 3, MR3 is working and it is more powerful, so medial squint. So these are some of the lesions which you have to discuss. But before you discuss the lesion, you have to discuss the course also. First is oculomotor nerve. So when you're talking about oculomotor nerve number 3 coming from the midbrain at the level of superior colliculus, periaqueductal gray, if you remember, it is coming from midbrain at the level of superior colliculus, periaqueductal gray. It was passing through the two arteries I told you. Do you remember? Superior cerebellar and posterior cerebral, and then it is a content of the cavernous sinus, lateral wall of cavernous sinus, and content of superior orbital fissure, and content of the orbit to supply almost all the eyeball muscle except superior oblique and lateral rectus, the formula of eyeball. So where is it coming from? It is coming from the place where you have red nucleus, in the midbrain at the level of superior colliculus. So at the level of superior colliculus, there is a periaqueductal gray, and in the periaqueductal gray you have the abducent nucleus, and you have the oculomotor nucleus and giving oculomotor nerve, which is passing here between the two arteries. Which two arteries? Do you remember there was a Weber syndrome damaging the crus cerebri, third nerve, and substantia nigra? Anterior midbrain syndrome, Weber syndrome. So leading to same-sided oculomotor palsy. Same-sided eye goes down and out, Weber syndrome. You remember that? So this is oculomotor nucleus, and this oculomotor nucleus is giving oculomotor nerve can be damaged in Weber syndrome, which is anterior midbrain syndrome, which will also damage the crus cerebri and substantia nigra. So when the Weber syndrome is there, there is ipsilateral down and out eye. We'll discuss about that later. It is passing between the two arteries, which are superior cerebellar and posterior cerebral, and then content of cavernous sinus in the lateral wall of cavernous sinus, and then it is passing through the superior parietal fissure. Two divisions were given, you remember? There was upper division and lower division, and both are passing inside the ring of Zinn to supply almost all muscle except the lateral rectus, because LR6 supplied by 6th nerve, and the superior oblique, because superior oblique will be supplied by trochlear. So this is the course of the nerve. Now you will find that we have to discuss some nuclei. For example, you have known earlier that there is one Edinger-Westphal nucleus which is parasympathetic to control two muscles using ciliary ganglion. One is sphincter pupillae, one is ciliaris for light reflex and accommodation reflex. And then there is oculomotor nucleus, which is somatic or skeletal muscles to control, means almost all the skeletal muscles of the eyeball except superior oblique and lateral rectus. So there are two components. One is GSE and one is GBE. What is GSE? G for general, S for skeletal or somatic, E for muscle, general skeletal muscle. And what is GBE? General visceral muscle. If you say general visceral muscle, who is the visceral muscle here? The smooth muscle or the visceral, general visceral muscle. So Edinger-Westphal is GBE? Yes. And motor nucleus of the oculomotor is GSE? Yes. Okay. Now what are the nuclei doing? You know already. You have discussed. Edinger-Westphal nucleus is sending the fibers and is passing to the ciliary ganglion to carrying the preganglionic fiber. Who is carrying postganglionic now? The postganglionic, I think, will be carried by branches of the trigeminal. Yes, branches of trigeminal to control sphincter pupillae for meiosis, ciliaris to increase the lens convexity for accommodation. Accommodation reflex, light reflex? Yes. Are you talking about short ciliary nerve here? Yes, short ciliary nerves. Short ciliary nerves. Then who is supplying dilator pupillae? Dilator pupillae is a different thing. It's a radial arrangement of fibers. Yeah, who is supplying the radial arrangement of fiber? I told you, long ciliary nerves. And what about the long ciliary nerve? Long ciliary nerves are actually carrying the sympathetic fiber. Which sympathetic fiber? T1 sympathetic fiber. From where? Superior cervical ganglion. Oh, the Horner syndrome thing? Yes. So superior cervical ganglion sending some T1 sympathetic fiber to the long ciliary nerve to the dilator pupillae for mydriasis. Yes, it will be compromised in Horner syndrome. Horner syndrome is injury of T1 sympathetic fiber. So it is different. It is long ciliary nerve. And what is the motor nucleus doing? You don't know what is motor nucleus doing. Motor nucleus is supposed to supply all the muscles. The formula is there. LR6, SO4, remainder 3 means except the lateral rectus and superior oblique. All the muscles of the eyeball is under third nerve. Could be levator palpebris superior or superior rectus, medial rectus, inferior rectus or inferior oblique, whatever. Skeletal muscles, they are all supplied by third nerve except superior oblique and lateral rectus, motor nucleus. So there is a superior division for the superior rectus, yes. And there is inferior division which is related to the ciliary ganglion, yes. That was carrying parasympathetic fiber. So inferior division is carrying parasympathetic fiber to ciliary ganglion, yes. And then it will supply the inferior rectus, yes. So the oculomotor nerve has two divisions, superior and inferior division in the common tendinous ring of Zinn, passing superior parietal fissure. Yeah, that is the time it has. And inferior division is related to the ciliary ganglion, and then it is supplying inferior rectus. Yeah, inferior division, inferior rectus, that's how. Okay, then what is the next thing? Next thing is the lesion. What will happen if there's a lesion? So now you are telling that this is third nerve of the right side. Yeah, third nerve of right side, it is lesion now. So what will happen if third nerve of the right side is lesion? The eye goes down and out. Why the eye goes down or out? Tell me. There is also ptosis. Why there is ptosis? Tell me. There is also fixed and dilated pupil. But why there is a fixed and dilated pupil? Let us see why. You have to understand that this is the midline of the body, nose is here. The patient is looking at us, this is the right eye. Oculomotor nerve is lesion on the right side. So let us see what happens. So this is the nose of the patient from the front view. Yes. Right eye and third nerve is gone. Yes. And left is okay. Yeah. So this is the pupil of the left eye. Let us look at the pupil of the right eye. Also look at the upper eyelid. See, this is the upper eyelid and this is the upper eyelid. Why? What happened here? What happened here is ptosis. But why there is ptosis? Because LPS is gone. Why LPS is gone? Because it is supplied by third nerve majorly. So you're telling that if there's a right-sided oculomotor nerve injury, right-sided eye will have ptosis? Yes. Because the levator palpebrae superior is majorly supplied by oculomotor nerve? Yes. What about the pupil? Pupil, tell me about the pupil. You see the pupil yourself and you'll find the pupil is dilated. Why the pupil is dilated? Why the pupil is dilated? Because dilated pupillae is unopposed. But why the dilated pupillae is unopposed? Dilated pupillae is unopposed because the sphincter pupillae is paralyzed. But why the sphincter pupillae is paralyzed? Why there is mydriasis in this patient? Because the sphincter pupillae is supplied by third nerve is gone. So third nerve is gone, the sphincter pupillae is gone. Yes. So dilated pupillae become more powerful. Yes. That's why there is mydriasis. Of course, see, if there is a right-sided oculomotor nerve injury, then right sphincter pupil is not working. So right dilated pupil is more powerful. There will be a fixed and dilated pupil. What is that? There will be a fixed and dilated pupil. What do you mean by fixed and dilated pupil? Why it is fixed? Fixed pupil means no response to light reflex. But why there is no response to light reflex? You are showing the light. Why there is no meiosis? Why there is no meiosis? Because sphincter pupil is not working. That's why. So telling that it has become fixed dilated pupil. Yes. What is fixed pupil? Fixed pupil means no response to light reflex. You are showing light. It is not dilating. Why? Because it's already dilated. It is in mydriasis. Oh, that's why. Yes. So fixed and dilated pupil. Yes. Okay. Can you tell me why this eye is going down and out? Why it is going down and out? Not only it will go down and out, it will be also in intorsion. Oh, you are talking about superior oblique muscle taking the eye down, out and causing intorsion. Yeah, that is what. So, because third nerve is not working, fourth nerve is unopposed. Yes, if third nerve is not working, fourth nerve is unopposed. And when the fourth nerve is unopposed, it will take the eye down and out and cause intorsion. So, eye is down and out intorsion. There is a squint. Yes, there is a squint, downward and outward squint. And moreover, see, lateral rectus is also unopposed. Why lateral rectus is unopposed? Because if third nerve is not working, sixth is unopposed. If third nerve is not working, sixth is unopposed. So it will take the eye out. You mean to say again out? Yes, it is down and out eye, helping superior oblique muscle to take it out. So that is why there is a down and out eye in oculomotor nerve lesion. Yes, there is a down and out eye in oculomotor nerve lesion because third nerve is not working. So nerve number 6 and 4 have become more powerful. And who is supplying dilated pupillae? Dilated pupillae, you know, it is supplied by the T1 sympathetic fiber. So is the T1 sympathetic fiber still working? Yeah, of course, they must be working. That is why the dilated pupillae is still working. The problem was with third nerve. Third nerve was not working. Okay, down and out eye. Yes. With the ptosis. Yes. Fixed and dilated pupil. Yes. Is a sign in Weber syndrome. Yeah, in Weber syndrome, this sign will be there on oculomotor same side, but the other problems will be on the contralateral side. Why the other problems contralateral? Because pyramidal tract crosses. That is why. So there will be contralateral spastic paralysis. Yes. Oculomotor same side, but contralateral spastic paralysis. And Parkinson's disorder on the opposite side. Why? Because it is also contralaterally controlled. So pill rolling tremor on the other side. This is right-sided Weber syndrome, yes, but left-sided Parkinson's, yes. Okay. What about the trochlear nerve? Trochlear nerve, I'll tell you the course and some 4 points for the fourth nerve. 4 points for the fourth nerve. Yes. What are the 4 points for the fourth nerve? Let us see, but first you tell the first point. What is the first point? You remember I have told you trochlear nerve is the thinnest cranial nerve. You can also say smallest. But why it is thinnest, smallest? Because it has very few axons. Very few axons. So that is why it is the thinnest, smallest. Yes. You can also say slimmest. Thinnest, smallest, slimmest. Various terminologies in English. Yes, your English should be good here. Why? Because I'll take you to a question and then you will be confused. So your English should be good. Thinnest, smallest and slimmest. You want the synonyms. No, I want the antonyms. You tell me the antonyms now. We'll have to use the antonyms, you know, to deal with the question. Anyway, what is the other point? Other point I told you. This nerve has longest intracranial course. Why this nerve has longest intracranial course? Because I told you this nerve has the only nerve with the dorsal exit. It went dorsal and came ventral. That is why it became long. Longest intracranial course. So this is the only nerve with dorsal exit. Yes. And that is why it has longest intracranial course. Yes. What is the fourth point for the fourth nerve? Fourth point for the fourth nerve is it has internal decussation. Internal decussation. Like optic nerve is having decussation of the peripheral temporal vision fiber. Optic chiasma. Yes. Trochlear nerve also has chiasma. Yes, but not seen outside. It is inside in the brain. So it is internal crossing, internal decussation. Where internal decussation? Where? It is in the midbrain. Yeah, midbrain, but where in the midbrain is a question. They're asking where is internal decussation of the trochlear nerve is happening. So we'll have to find out. And remember, it is the smallest cranial nerve, thinnest, slimmest, and it's the only cranial nerve with a dorsal exit from the brainstem, and it is having longest intracranial course. But these 3 points you already told us. Yeah, this is a revision. Oh, this is a revision. Okay. Then what is the fourth point? That also will revise. See here. This is the inferior colliculus level. How do you know? Because I got the trochlear nucleus. Okay, you got the trochlear nucleus now. Yes. So inferior colliculus level. Yes. Do you remember even the fourth nerve is, first of all, it has a dorsal exit. And the only cranial nerve with dorsal exit is trochlear nerve, and then it is passing between the two arteries. Same name. You mean to say like oculomotor? Yes. Oh, so posterior cerebral and superior cerebellar artery sandwich between the two. Yes, if you remember, we have discussed that earlier as well. Then it is passing through the cavernous sinus, the lateral wall of cavernous sinus. Yes, lateral wall of cavernous sinus with oculomotor. And then it is passing through the superior orbital fissure, left outside the ring of Zinn. Yes, left outside the ring of Zinn, and supplying superior oblique muscle there for that downward, outward, and intorsion movement. Downward, outward, and intorsion movement. Okay, I think it is called trochlear nerve because the muscle is hooking under some trochlea in the orbit. Yes, the superior oblique is hooking under trochlea in the orbit, so nerve is called trochlear nerve supplying superior oblique muscle. Okay, trochlear nerve, right. What is the other thing? Other thing you have to understand one thing here. See, it is the right nucleus which is giving us, it is the right nucleus which is giving us the left nerve. Supplying left superior oblique muscle, and it is the left nucleus. It is the left nucleus which is giving us a right trochlear nerve to supplying the right superior oblique muscle. You mean to superior oblique muscle has contralateral innervation? Yes, remember, superior oblique muscle will have contralateral innervation. The left nucleus is giving supply to the right superior oblique muscle, so it has contralateral innervation similar to that. Right trochlear nucleus is giving supply to the left superior oblique muscle, so contralateral innervation. This is one thing. Second thing, if the right nucleus gave you left trochlear nerve, you call it as left trochlear nerve. Why would I call left trochlear nerve? Because it is on the left side. Can't you see? Oh, that is why. Yes. But it is wrong. Yeah, it is wrong, but we call it like that. It may be a misnomer. See, nucleus was on the right side. Nerve went to left side. So, in fact, it is which nerve? It is right trochlear nerve, but we call it as left trochlear nerve. Why you call it as left trochlear nerve? Because it is on the left side? Yes. What will happen if I damage the left trochlear nerve? If you damage left trochlear nerve, left superior oblique will be paralyzed? Yes. What if I damage the right trochlear nucleus? If you damage the right trochlear nucleus, then left superior oblique will be paralyzed? Understand, if you damage the right trochlear nucleus, left superior oblique is paralyzed. But if you damage the left trochlear nerve, left superior oblique is paralyzed. You mean to say this is actually right trochlear nerve but called as left trochlear nerve because it is running on the left side, so it is kind of a misnomer. I should have called it as right trochlear nerve? Yeah, maybe. But it is called as left trochlear. So be careful. So where is this crossing happening? Right nucleus sending the left trochlear nerve and the left nucleus sending right trochlear nerve. Where is the crossing? It is in the midbrain internal decussation. If you say it is in the midbrain internal decussation, where? It is called as superior medullary velum. This is called superior medullary velum, and superior medullary velum is at the roof of the fourth ventricle behind the brainstem. You remember, behind the brainstem you have fourth ventricle. So behind the brainstem we have fourth ventricle. Yes. So behind the brainstem we have fourth ventricle, and the fourth ventricle has a roof of cerebellum, I believe. Yes, cerebellum is the roof, but superior medullary velum is also the roof. So superior medullary velum is the roof of the fourth ventricle. Yes. And brainstem is the floor. Yes. And the fiber crossing in the superior medullary velum. Yes. Okay. If you say so. This nerve has internal decussation in the midbrain. Yes, internal, because you cannot see it outside, it is inside the brain. That's why internal. Look at the Harrison medicine now. Why should I look into Harrison medicine? Because there are questions, you have to deal with the questions. That is why. See here. Trochlear nerve is innervating contralateral superior oblique muscle. What do you say? Trochlear nerve or trochlear nucleus? So this is a mistake in Harrison medicine. Maybe. So you are telling that they should have written trochlear nucleus? Yes. Not a trochlear nerve? No. So what should I do? This is Harrison. You have to follow Harrison. You mean to say somebody asking me trochlear nerve innervating the contralateral superior, I should say yes? Yeah, you should say yes because written in Harrison, but it is wrong. In fact, technically. Why technically wrong? Because technically it is trochlear nucleus which is innervating contralateral superior oblique, not the nerve. Anyway, remember that other way. You mean to say superior oblique has contralateral innervation that way? Yes, maybe nucleus, maybe nerve. And this is the muscle you have known, superior oblique SO4. You remember what is superior oblique doing? You have seen the left eye, what it was doing. Takes the eye down and out and cause intorsion, inward rotation. Take the eye towards the... So you're telling that depression and intorsion. Yes, but Harrison is giving 2 only. Do you have a third one? Where did you get the third one? You are telling DOI, down, out and intorsion. I saw only down and intorsion. What about the outward? Who's telling the outward? Gray's Anatomy tells it is abductor also. So Gray's Anatomy tells abductor also, but what should be my first answer? Intorter. First answer, intorter. Second answer, depressor. And third answer, abductor. So chiefly intorter? Yes, chiefly intorter. Then depressor? Yes. And then abductor? Yes. In a sequence? Yes. Okay. Let us look at the left eyeball again. No, you have already looked at that, in fact, and you have already told me the activity. What was the activity? Do you remember? It takes the eye down and out and cause intorsion. So it is taking the eye down, out and causing intorsion. Where is intorsion? This one. That is intorsion. Oh, you mean to say when I turn the eye inward, this is intorsion? Yes, that is superior oblique muscle doing the job on the left side. This is left eyeball. This is left eyeball. So this is left eyeball written here. Yes, left eyeball written there. Okay, so down, out and intorsion. Yes, that's why it is also called as copying muscle. What is happening here? Some school test is going on and this person don't know nothing. So the other person is brilliantly writing something. So I'll copy. How? Take my eye down and out and copy without my madam noticing me. My madam should not notice me. If I move my head, then madam will say, why are you looking at his copy? Look at your own copy. I'll not move my head, move my eye, copying muscle. Or taking the eye down and out. Yes, superior oblique. Okay. Maybe that is the action of the muscle. But how do you check it clinically is different. So how do you do clinical testing for superior oblique? For clinical testing of superior oblique, you have to ask the patient to look at his nose, tip of his nose. Clinical testing, how it is done? Looking at the tip of his nose. You mean to say, in adducted eye, I have to do depression? Yes. In adducted eye, depression is chiefly done by the superior oblique muscle. This is how you check it. In the adducted eye, the depression is chiefly done by superior oblique. This is how you test it. Ask him to look at the tip of his nose or give him something to read. Give him something to read. This is how you check it. You mean to say in the adducted eye, depression is chiefly done by superior oblique muscle? Yes. Then what is inferior rectus doing? I thought it is a depressor. Yeah, it is, but it is weak depressor now. If inferior rectus is a weak depressor in adducted eye, then when it is a strong depressor, when the eye is abducted? You mean to say when the eye is abducted, I want to do depression now. If the eye is abducted and I want to do depression now, which muscle is helping me? Superior oblique is not helping me. Yeah, it is helping, but it is weak depressor. There is weak depressor. That time, which is the chief depressor? The inferior rectus. Simple thing. If the eye is abducted, depression is done by inferior rectus assisted by superior oblique. But if the eye is adducted, depression is done by superior oblique assisted by the inferior rectus. So telling that inferior rectus is more powerfully depressing the eye in abducted position. Yes. Assisted by superior oblique muscle there. Okay. How do I check the superior oblique muscle? You see, to check the superior oblique muscle, you have to tell the patient in adducted eye depression. So you have to ask the patient to adduct the eye and depression. Yes, it is actually in adducted eye you have to ask the patient to do depression. Means the patient has already used the middle rectus. Yes, middle rectus. And then you are using the superior oblique. Yes, superior oblique. Because in the adducted eye, depression is chiefly done by superior oblique. So how will I check inferior rectus? If you want to check inferior rectus, obviously you will ask the patient to do depression in abducted eye. So if I want to check the inferior rectus, I will ask the patient to do depression in the abducted eye. Yes, that is how you check it. This is the point here. This is how you check the muscles. Yes, this is how we check the muscles. See, Now the superior oblique is not working and there is a vertical diplopia due to trochlear nerve lesion, and patient has difficulty reading and looking down. Why? Because if you want to read or look down, especially while going downstairs, your eyes are in adduction and you are doing depression. So there will be diplopia, vertical diplopia. And let us say left superior oblique is not working, and when I am reading there will be diplopia, and when I go downstairs I'll fall down. Why? Because there's diplopia, you know. So during the course of the disease, the patient will learn something. What? He will be tilting his head contralateral. You mean to say if left superior oblique is not working, he will tilt his head to the right side? Yes, contralateral head tilt according to Harrison medicine. And then they go downstairs? Yes, then they go downstairs. Can I see such a diagram now? Yes, you will see the diagram. Let us see the diagram. This is the diagram. What is this? You see, this is the left trochlear nucleus. Yeah. This is left trochlear nucleus, which is giving us right superior oblique muscle. Left trochlear nucleus giving the right superior oblique supply. Yes, contralateral. So left trochlear nucleus is giving the right superior oblique muscle supply. Yes. Okay, that's good. So what about the left one? Left one, you can see what it will be there. If it is the right nucleus, the trochlear nucleus is actually shown here. They have shown here. So as you see, trochlear nucleus, this would have come from here. So you are telling that left nucleus will supply the right superior oblique, fine, and the right nucleus will supply the left superior oblique. Yes, that is the point here. That's what we are going to discuss now. So this is the right nucleus which is now supplying the left muscle. Yes, and it's gone. This one is gone. Yes. Tell me what will happen. You are telling that there is the right nucleus. Yes, and which is supplying the left superior oblique. Yes, you see here, left trochlear nerve it is called. Right trochlear nerve is called left trochlear nerve. Yes, maybe it is a misnomer. So right nucleus giving right trochlear nerve, but it is called left trochlear nerve because it is on the left side. Yes, it's gone. Now see what will happen. If it is gone, then I know what will happen. One intortor is not working. Extorters will be more powerful. One intortor is not working, so extorters will be more powerful. And when the extorters are more powerful, the eye will be in extortion. I will go into extortion, leading to diplopia. So left eye will be in extortion, leading to diplopia. Especially when the patient is looking downward, reading a book or going downstairs. So they learn something. If the left superior oblique is not working, they tilt the head to right side, and somehow that diplopia is compensated. Oh, that is why this lady is turning the head to the right side? Yes, because lesion of left trochlear nerve or right trochlear nucleus. Can you see here? Oh, this is lesion of left trochlear nerve or the lesion of the right trochlear nucleus. Yes, that's what I told you. If there's a left trochlear nerve injured, the head will be contralaterally tilted because left eye was in extortion. Because intortor is not working, superior oblique is a powerful intortor, it's not working. So extorters are more powerful, eye remains in extortion leading to diplopia. You have to bring it back. Or bring the eye back. Yes, bring the eye back. That's what we do. Okay, we are bringing the eye back now. Yes, it is the right trochlear nucleus giving the left trochlear nerve. Yes, and that is the one which is lesion and left superior oblique not working. Yes, that's why this lady is tilting the head to right side. Yes, that's the point here. Tell me the answer. Trochlear nerve accept? Yes, tell me the answer. Trochlear nerve accept. I think first statement is correct. Yeah, if you follow Harrison medicine, then it is correct. Otherwise it is wrong. You should have written nucleus. But anyway, you have to take it correct because it is a statement by Harrison. Maybe it is correct. Number 2, causes depression of the adducted eye. That is correct. Superior oblique does that. Adducted eye depression, that is there. Lies outside the ring of Zinn. Trochlear nerve left outside the ring of Zinn. That is correct. Patient attains ipsilateral. No, it is contralateral. That is why this is wrong. That is why this is the answer. So answer is choice number D, because it is contralateral. If the left superior oblique is not working, I will tilt to the face to the head to right side. So contralateral is not ipsilateral. So D is the answer. What if I remove D? If you remove D, maybe then I will take my answer as A. Why? Because it is not the nerve, it is the nucleus. But then this question has double answer. Yes. But still this is better answer. Yes. Okay. So this is better answer because this is always correct. Yes. So this is a statement by Harrison. So you giving some preference to this one. Yes. Otherwise this is also wrong. Yeah, of course. It is not the nerve. It is the nucleus. So it is also wrong. But in this particular question, D is a better answer. If D is not found, then you say A is also wrong, is the answer. Similarly, you are telling that D is the answer, fine, but similarly, you will find this question, all is true about trochlear nerve except. Again, trochlear nerve, yes, tell me the exception. If you want me to tell exception, I think slendermost nerve is this. Yeah, slendermost, I told you. Slimmest, thinnest, smallest, slendermost, English, synonyms. Okay, longest interdural, no. Why? Because this was abducent. Yeah, correct. So this is the answer. What about choice number C? Sir, this is written by Harrison Medicine. Yeah, okay. Benefit of doubt, no problem. Take it correct because the statement by Harrison, but Harrison, it is not the nerve, it should be nucleus. But anyway, you already found your answer. That is not trochlear, that is abducent. So what about choice number D? Of course it shows internal decussation. What if I remove choice number B? If you remove choice number B, then I will take my answer as choice number C also. It is also wrong because it is not the nerve, it is actually the nucleus. So this question has double answer. Yes, it is, but you cannot have double answer. So this is your first answer because trochlear is longest intracranial, not intradural. So I'll keep my answer as choice number B. Yes. Though choice number C is also wrong. Yes, it is wrong, but it is given by Harrison. You cannot say Harrison is writing some wrong statements. Technically it is wrong, but maybe it is a misnomer. We don't know. So this is the answer. Yeah, that is the answer. This is abducent, not trochlear. This is the answer. So abducent is longest intradural. Yeah, that's what I told you earlier, isn't it? Can I see the abducent nerve now? You want to see abducent nerve now? Yes. Okay. Let us see. LR6. LR6. As I talk about LR6, you see, this is abducent nucleus making a facial nerve making a hook around that before it exits. Facial colliculus? Yes, deep to facial colliculus. So you are telling that this is facial nucleus and it is coming out and hooking around the abducent nucleus? Yes. And producing some facial colliculus here at the floor of the fourth ventricle? Yes. And that nucleus is because of the axons of the facial nerve, not the abducent nucleus. Yes, that's what we learned. Okay, what is abducent nerve doing? Abducent nerve, first of all, it will come from the pons. And as the abducent nerve will come from the pons, it will be inferolateral to internal carotid artery running through the cavernous sinus, if you remember. You are telling it is in the cavernous sinus running alone? Yes, not in the lateral wall of cavernous sinus. So it is not in the lateral wall of cavernous sinus, it is through the cavernous sinus, inferolateral to this artery which is called internal carotid artery. Yes, and then it is passing inside the ring of Zinn. Yes, it is passing inside the ring of Zinn, which is in the superior orbital fissure and supply the lateral rectus muscle. This is all for the abducent nerve. Now, if you say so, what if the muscle is paralyzed? If the muscle is paralyzed, then you can tell yourself this is the abducent nucleus, abducent nerve, and this is abducent nucleus, abducent nerve, and right abducent is gone. right abducent is gone means LR6 is not working. Yeah. And when LR6 is not working, MR3 is more powerful. Yes. So medial squint. Yes. You have seen that in the case of cavernous sinus thrombosis. Remember, the earliest nerve to get involved is the abducent nerve. So lateral rectus paralyzed. So medial rectus more powerful. So medial squint. Early sign of cavernous sinus thrombosis. So you're telling that this is sixth nerve of the right side which is gone. Yes. And then right-sided lateral rectus is not working. Yes. Medial rectus is working, more powerful, unopposed. Yes. Medial squint. Yes, that's the point here. That is the point. All of these are MCQs, you know. Tell me the answer. What about cranial nerves? What is this? Abducent has long. No. Why? It is not abducent. Then who is that? Trochlear. Okay, right. So you got your answer immediately. What about the choice number B? Choice number B is okay. It is the trochlear nerve innervating contralateral superior oblique muscle. No problem. Okay, olfactory is the shortest. What does that mean? Shortest means length. Length. It is about the length. Shortest length. So it is because cribriform plate of ethmoid bone, shortest length, you remember? And the vagus has the largest distribution. Largest distribution means what? Means it is supplying head, neck, and then thorax, and then abdomen. So such a wide area of distribution. Let us write down some information which the examiner is interested in asking. But keep your answer as choice number A because it is not the abducent. It is the trochlear nerve which has the longest intracranial course. Choice A is wrong, and that is your answer. So keeping that answer, we will write down some information. And trochlear nerve internal degustation is no problem, and olfactory is the shortest, is no problem. Vagus has largest distribution, is no problem. Keep your answer as choice number B. Choice number A. Okay, what are the things you want to write down? Let me write it down, then you see. Trochlear nerve compared with the trigeminal. What about them? Trochlear nerve is the thinnest and the smallest cranial nerve. If you say smallest, what does that mean? That means size, smallest size. And what about trigeminal? Trigeminal is the thickest and the largest. Thickest and largest means size? Yeah, size. So you're telling that trochlear nerve is thinnest and the smallest size. Yes. And trigeminal is thickest. Why it is the thickest and largest size? Because it is trigeminal. It has a lot of axons. Trigeminal, 3 nerves into 1. 3 nerves into 1. Trigeminal, large number of axons. Oh, you are telling that trochlear nerve has only few axons. That's why it is thin? Yes. That's why. Okay. Then what about the shortest and longest? If you're talking about the shortest and the longest, then we'll see shortest means length and longest also means length. So who is the longest, who is the shortest? Shortest is the olfactory nerve. If you remember, it is starting from the roof of nose and synapsing in the olfactory bulb. So short length, shortest. And who is the longest? That is the 10th nerve, vagus. Also remember that vagus nerve, which is the longest cranial nerve, is also having the largest distribution in the body. Why would you say it is largest distribution in the body? Because it is supplying the head, neck, thorax, abdomen. Be careful between two questions. One will ask you, which is the largest cranial nerve? You will say trigeminal. But if somebody is asking you which is the nerve with largest distribution, then you should say vagus. So somebody asking largest cranial nerve, trigeminal, but somebody asking largest distribution in the body, vagus. Somebody asking you shortest cranial nerve, olfactory, but somebody asking you smallest cranial nerve. And it is not the length, it is the size. And then you have to answer trochlear nerve. Can you tell me which nerve has the longest intraosseous course? Longest intraosseous course, I think it is, yes, facial nerve? Yes, because it is running in the superior and posterior wall of middle ear cavity, giving 3 branches, if you remember. So the longest intraosseous, within bone? Yes, within bone. is the facial nerve, as it is running in the short distance in the superior and long distance in the posterior wall of the middle ear cavity. So longest intraosseous is facial nerve.